Dave, do I have the right background?
You have a Mount Rainier background, and it's fine.
Okay, Dave's like, yeah, good enough. All right, good morning, everyone. Let's go ahead and get this meeting to order. Due to COVID-19 and the Governor's Proclamation 20-28, we're meeting today via Zoom only, which we will do so until further notice. We're going to do a roll call to identify board members that are with us today. Terry House.
Good morning.
Allison Polson.
Good morning.
Morning, Allison. Pamela Cruz.
Good morning.
Carrie Schaefer.
Good morning.
Amy McGuire.
Good morning.
Well, you all are fast on your mute buttons. Very nice. Donna Hanson Murray.
Good morning.
Dan Gossett.
Good morning, everyone.
Pete Cutler. Dave, do we know if Pete's with us today?
We do not have Pete at this point. We'll double check on him.
Got it. And Katie Hatfield from the AGOs. Katie, you with us?
Hello, everybody. Good morning.
Morning. And I'm Lou McDermott. I'm the chair of the SEB board and the deputy director for HCA. With both board members and presenters attending virtually, it's really helpful if the board can hold their questions until each presentation is done or when the presenter pauses and asks for questions. Board members are also going to be watching in case you use your Zoom hand, your Zoom feature to indicate you have a question. The public's going to have an opportunity to provide general comments at the end of the meeting during the public comment period. And Dave's going to provide an overview of today's agenda.
All right. Good morning, Chair McDermott and members of the board. Today is probably, I think, the shortest board meeting that has ever been scheduled, public portion of a board meeting that I think has ever been scheduled for the SEB board. So you're not imagining things if it does feel like a relatively quick meeting. We'll start off primarily with a presentation from Lauren about some of the annual procurement activities that are going on as we start to describe publicly some of the potential benefit changes that could be rolled up in the rates that we've been previewing and discussing in executive sessions to date. But we'll start to roll out and describe publicly again some of those potential benefit changes that could happen in the portfolio, which then moves us into a presentation by Christine Davis with some benefit design resolutions related to the Uniform Medical Plan, specifically with the UMP high deductible HSA IRS, there were a lot of acronyms there, qualified plan for 2023. So those are the public portions of the meeting, and then we will move into an executive session to continue some of our proprietary rate conversations as part of the negotiation process. So a very quick meeting from the public perspective, and then moving into the into executive session. I do want to highlight that the members of HCA, I would just like to highlight what our backgrounds are. We'll have a spring Mount Rainier purple flower field image today, and then we will continue going through our tour of Washington in other future images. And I do want to acknowledge that Pete has joined here, Lou, and I will turn it back to you.
All right, is this the one, Dave?
Yeah, oh, no, that's Lavender Fields of Squim.
You know, I'm going to go with that. All right.
You can
Pete,
take
welcome. Our first agenda item is approval of the meeting minutes. We're going to vote on the June 24th, 2021 meeting minutes. They're behind tab number 3. Are there any comments from the board? Do I have a motion to approve the minutes as written?
This is Allison, so moved.
Thank you, Allison. Is there a second?
This is Dan. I'll second that.
Thank you, Dan. All in favor, say aye.
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 Any
Aye.
opposed? All right, thank you. The June 24th, 2021 minutes are approved as written. The next agenda item is a follow-up from the May 5th meeting. Dave's going to provide some insights on a few questions that came up during that meeting.
All right, good morning again, everyone. Just a few pieces of follow-up information related to dental and vision benefits. And I did want to start off by saying I'm not anticipating bringing additional presentations back to the board this season on either of those benefit pieces. So I'll provide the follow-up questions here, and then if there are additional questions, we can certainly work to answer them. But the process now is moving into actually writing decision packages that could be submitted as part of the biennial process. And the one thing that I do want to assure people of is that the way that the dental package is currently being drafted would include not just the 5 benefits that were kind of described at the start of the journey, but also that 6th crown benefit that this board has expressed a lot of interest in. And so I just did want to reassure the board that the way the package is being drafted would include all 6 of those proposals as a menu of options that could be selected, and that the boards, both boards, stated discussions and preferences will be described in the narrative of that as well. But I did want to reassure you that there will be 6 different parts of that. The 5 that were described in many of the materials, and the 6th one that was added as part of the discussion. But moving to some of the specific questions, Donna, you had asked about how standard a non-duplication of benefits component of uniform dental plan, how common that is in other dental commercial insurance. And I have 2 kind of data points for you. The first is we worked with Delta to look at their overall book of business for all of their group plans, and about 90% of their group plans have that non-duplication policy as the uniform, like the uniform dental plan, and about 10% of them do not. But honing in a little bit more than just the overall group plans, if you look at what are called jumbo groups, and jumbo is usually defined as 10,000 or more subscribers. So, you know, SEB is super jumbo. It's not just jumbo, but a large employer of 10,000 subscribers or more. It's more about a 50-50 split as you get into that standard, with a little bit of the weight headed towards I don't want to do the double negative of having coordination of benefits instead of non-duplication of benefits. So it's about even, but a little bit more on the coordination of benefits side. So overall, a heavy slant and the commercial market is in the non-duplication of benefits, just like the uniform dental plan. When you look at for large employers, it's a more even split as to whether that's a feature of the plan. That was the first question. The second question that I had for dental was to provide some information about individuals in SEB members who are not getting Class 1 services, so those preventive cleaning type services, but are getting Class 2 services like a filling. So people who are getting fillings, for example, but not having gotten their cleanings previously. There was a question as to how many people fall into that type of scenario. And the data so far for the last plan year was that about 6% of the member population was utilizing Class 2 services without having gotten cleaning services. That relates, I believe, to the incentive plan design and that motivation to access preventive services to maybe reduce your out-of-pocket cost share of a Class 2 service. That was the specific question that I had labeled to come back, and I believe Dan or Terry or both asked about that one. I just want to pause. I have a third follow-up, which is vision related, but are there any additional questions about anything I brought back about dental at this point? Okay. The vision question that was asked, I believe this was by Donna, was if there is any data that we could share about how and what members are actually spending their allowance on right now. So there's a $150 allowance. The question was, can we describe whether that's on glasses, whether it's on lens enhancements, whether it's on contacts or fitting fees. And the unfortunate aspect of it is we only know whether the benefit is utilized. We don't know what it's utilized for. So we aren't able to break down what the how that $150 is being spent. So for example, if I go out and I spend, use my $150 for a box or two of contacts and or the fitting fee, and then I go and spend out of pocket for glasses, that would be indistinguishable from Connie, who goes and gets glasses with her allowance and then pays out of pocket for contacts. All we know is that Dave and Connie both spent their $150 allowance. We don't know which way they spent it, and we would actually have no insight into Dave and Connie's out-of-pocket expenses beyond the allowance either, which is partly why we did the survey, to get some data from the members that we're serving in both populations as to what they are saying their actual expenditures are, because we don't have a window into that otherwise. And then the last question will actually be addressed in Lauren's presentation, which was about adding some, or having some comparison about the Primera proposal to change one of its plans to a new plan. And so that will be in Lauren's presentation momentarily. Those are the follow-ups that I have from the last board meeting. And I'll pause for any questions before turning it back to Lou.
All right, hearing no questions. Thanks, Dave. Our next agenda item, 2023 Annual Procurement Update. Lauren Johnston, SEB Program Procurement Manager, ERB Division, is going to provide an update on the 23 annual procurement process. Her materials are behind tab number 4. Lauren, good to see you.
Thank you, Lou. Good to see you too. Good morning, Chair McDermott, members of the board. For the record, my name is Lauren Johnston, and I am the SEB Procurement Manager. Today, I'm going to be going through the 2023 Annual Procurement Update. Next slide, please. So just wanted to be able to provide you an overview of the medical plan procurement work plan. So we submitted a request for renewal on February 25th to all of our carriers. The responses were received on April 8th, with negotiations beginning on April 11th. And then there are now board presentations of those negotiated results between now and the July board meetings, with a final vote in July of 2022. So those will be on the employee premium resolutions. Next slide. First, just kind of wanted to touch base on something that all of our carriers are going to be doing. There was some legislation passed this year, Senate Bill 5564, which caps the insulin at $35 a month. So just wanted to make the statement that all of our SEB medical plans will be complying with this bill. Next slide. So next up, we're going to go through some Kaiser Foundation Health Plan of the Northwest, also referred to as KP Northwest, and Kaiser Foundation Health Plan of Washington, also referred to as KP WA, proposed changes. Just to make a note that KP Northwest operates in Southwest Washington, as well as some counties in Oregon. So we're going to start with them. So KP Northwest is proposing some changes for 2023 in regards to their maximum out-of-pockets. So for all 3 of their plans, KP Northwest 1, 2, and 3, the employee-only out-of-pocket max will be increasing by $500, and all other tiers will be increasing by $1,000. Oh, sorry, yeah, sorry. I'll wait for a sec so you can catch up on that slide. So this is a low impact benefit change that KP Northwest is making to keep premiums stable. It impacts a small number of members who meet the out-of-pocket maximum every year, but everyone will get to benefit from the lower premium by making this change. Just to add some numbers, overall in 2020, only 5.2% of SEB members met their maximum out-of-pocket, and in 2021, that percentage was 5.7%. Next slide. Some book of business changes that KP Northwest is making for 2023. They're going to be implementing an advanced care at home program. So this would be when a member is clinically appropriate, that they would have the option of this program to be treated and recuperate at home instead of within a hospital or other facility. And then another change that they're making, this was basically just an oversight from the change that was made last year. or for plan year 2022 with their naturopathic services. They're going to be expanding that to dependents who live outside of the plan area. So what they did last year was they moved naturopathic services under their base care. And so this is just, this is just moving to align that with what they did last year. Next slide. So to kind of wrap up something that KP Northwest and KP Washington are both doing, just note that this does not apply to KP Washington options because they are not in PEB, but there's going to be some accumulator transfer changes. So these will be effective January 1 of 2023. So when the subscriber changes from between the SEB and PEB programs and stays within the same carrier, their accumulators will transfer. The exception to this is when someone is transferring into or out of the PEB KP Northwest CDHP plan. So what this means is that medical and pharmacy cost share accumulators, which include deductibles and out-of-pocket limits for all members, will transfer over when you switch from one carrier to another. So if I were to go from KP Northwest 1 in SEB, and I were to move over and become a public employee and enroll in KP Northwest Classic, my deductible accumulators and my out-of-pocket maximum accumulators would transfer over. So I would not need to start over at 0 again. So this does not include when a spouse or dependent child becomes the subscriber on their own account. So if my spouse was on my account now as a covered dependent and they became a public employee, their accumulators would start over because they are now a new subscriber on their own account. Next slide, please. So moving to KPWA and KPWA options changes, they are going to be implementing a first fill program. So this is a pharmacy program. It's for maintenance drugs only. It includes the first prescription that can be filled at any in-network pharmacy, but any additional refills will be filled via mail order or at a Kaiser Permanente retail pharmacy. So this does not apply to medications for setting conditions or to drugs that Kaiser cannot mail. So some of the reasons that they're doing this, they feel like there's more safety around this. So pharmacists can ensure that members avoid negative drug interactions and other risks. And there's more cost effectiveness to members as well, because the pharmacist can ensure that there's the use of generics when medically appropriate. And Kaiser also has the ability to negotiate better drug prices. So that'll start in 2023. And that's for both the HMO and the PPO plans for KPWA. Next slide, please. Some additional KPWA and KPWA option book of business changes. So they are also implementing the Advanced Care at Home program. And they're also making some changes subject to the deductible. So bear with me here while I kind of explain this. So right now it's different between KPWA and KPWA options. So if I were to go into an office visit and have a minor surgery done, it's covered differently between KPWA and KPWA options. Under KPWA options, I would go in and I would pay my copay, and I would not have to, there would not be no, it would not be subject to deductible. Whereas under KPWA, if I received the same services, I would be paying a co-insurance. Oh wait, actually I might have that. Yeah, so I'd pay the copay for the office visit, but any other services that I received, so all the professional services that I received that had to do with that surgery, I would be paying a co-insurance towards, and then I would need to meet my deductible as well. So they're kind of switching things up here to align them a little bit. So what's going to be happening now is that minor surgeries that can be received in an office setting will no longer be subject to deductible or co-insurance under KPWA. So under both plans, I would go in, and if I had a minor surgery, I would just pay a copay for all the services that I receive, except for lab and diagnostics. That would still be covered under a co-insurance with deductible. And I would not need to meet my deductible prior to paying that copay for those professional services. So the slight difference there for KPWA options is that this currently applies to ambulatory surgery centers as well as outpatient visits. So if I were to have the same services done now in KPWA options, I would only pay the copay and it would not be subject to deductible. So that is changing on KPWA. So those services now would be covered as a coinsurance and subject to deductible. Are there any questions on that one before I move on? That one's a little, it can be a little confusing and hard to wrap your head around. It took me a while also. All right, next slide, please. Some additional book of business changes for KPWA and KPWA options. They're going to be moving some of their well care service codes off of their preventive care, off of their preventive codes list. So right now they're covering codes as preventive that are not required federally or by the state. So these codes will have a cost share going forward. Most of these codes are lab and radiology services that are not considered medically necessary to diagnose or treat a condition that is not considered preventive. So they're going to be aligning with their national policy. So previously they were covering codes as preventive that were not necessary at the state or federal level. Next slide. All right, so moving into Premera Blue Cross's proposed changes. Next slide. So they're making some changes to their pharmacy cost shares for, and so these are the cost shares for a 30-day supply that we have on this slide. And you may notice that the second column from the left there, it says Premera HMO. So we're going to get into that in the next few slides. But that is a new plan that Premera is proposing for 2023. And you can see all of the new cost shares there that they would be proposing. And they do match what's under Premera High PPO and Premera Standard PPO. So all of the changes that are occurring are underlined and in italics. And just want to make a note there that cost shares are not prorated based on the length of treatment. If the actual cost of the drug is less than the stated cost share, the member is only responsible for the lesser of the two amounts. So if my prescription costs $5, I would pay $5 for my preferred generic drug instead of the $9 copay. Next slide. All right, Premera is also making some changes to their acupuncture, chiropractic, massage, and therapies benefits. They are changed for the CAM services. So chiropractic, acupuncture, massage therapy, they are moving to 24 visits per year. So that's they're doubling the number of visits per year per member. And they're also changing it from under the Premera High PPO and Premera Standard PPO. It's currently covered as a coinsurance, and so that is subject to deductible. It's moving to a copay. So what that means is that if I were to go in and have acupuncture done, I would not need to meet my deductible prior to paying just my copay. So I would just go in and I would just pay the $25 copay. And then on the Premera HMO, you'll notice that the cost there, the copays there for those services are less than under the Premera High and the Premera Standard PPO plans.
Lauren, I just want to highlight for the board, if a lot of that Lauren just described on CAM therapies is familiar or sounds deja vu, it should, because this is a very similar proposal to what the board adopted last year for the Uniform Medical Plan, moving from a co-insurance to copay model and increasing the visit limits to 24 a year. So this is sort of an alignment of kind of the ways the benefit is covered that Premera is proposing. And I'm sure everyone doesn't remember, but just as context, because I'm sure the question would be asked, the cost of the copay for chiropractic, acupuncture, and massage that was set in the Uniform Medical Plan was $15. So you see the UMP is between these proposals depending on the plan design. Just wanted to highlight that. And Pete, I see you have a question.
Yeah, I'm just curious what the current visit limitations are under the rehab therapies column?
Okay, so actually I can look at that really quick. Hang on just a sec.
This is one of those people where we all think we know the answer, but then we know that the nuances are enough that we always should check the document.
Right.
Yeah.
Yeah. And
Okay.
if it's not feasible to have the answer immediately.
No, I've got it. All right, so for PTSTOT, so physical therapy, speech therapy, occupational therapy, it is 45 combined visits per year.
Okay.
And then there are 45 visits for neurodevelopmental therapy per year. So a separate set of visits for those.
Okay, great. Thank you.
Yep. Next slide, please. Okay, so Premera is also proposing some changes to their office visits. So for office and clinic visits, mental health office and clinic visits, and then naturopathic physician services, they're changing the copay a little bit. So as you can see there, for a non-specialist, it's going up by $5, and then for a specialist, it's going up $10. And then you can see the new cost shares for the Premera HMO, which are all for non-specialists, $10, and then for a specialist, it would be $40. Next slide. Okay, so just wanted to highlight some additional changes for telemedicine and virtual care because we know that people are using those services more and more these days. So the copay on these are changing as well. And it'll match what, for the telemedicine, it'll match what's being done for the office and clinic visits. And then for virtual care behavioral health, moving to match that non-specialist dollar amount as well. Any questions there before we move on? All right, so next slide, please. Now we're going to be getting into the proposed plan changes for the Premera HMO. So Premera is retiring the Peak Care Exclusive Provider Organization, also referred to as Peak Care EPO, and they're going to be introducing the Premera Health Maintenance Organization, which we've been referring to as Premera HMO. So I just want to call out a few things here. They will be serving, the Premera HMO will be serving the same 3 county service area that the Peak Care EPO did. So that's Pierce, Thurston, and Spokane counties. The provider network will still revolve around multi-care as it does right now within the Peak Care EPO plan. There will be no out-of-network coverage except for emergency care and hearing hardware, which is the same as under the Peak Care EPO plan. One of the biggest differences, though, is that referrals will be required under the Premera HMO plan. So right now, under the Peak Care EPO plan, referrals are not required. Just want to point out that Premera did not submit rates or propose rates for their Peak Care EPO plan. So that means that either way, that plan would be going away for 2023. They do have plans to hopefully expand the service area for the Premera HMO as well in the near future. So we'll just keep an eye out for those changes in the future as well. Next slide, please. So we realize that there's going to be some questions around this, one of which would be, why is Premera proposing this change? So Premera is trying to work towards a more affordable, higher quality care within their plans. And this plan offers a streamlined digital experience, which we'll find out more in the upcoming months. So some things that members should expect is that they'll continue to have access to the multi-care health systems, multi-care connected care providers and hospitals, Marybridge Children's Hospital, as well as Premera's affiliated provider partner, Kinwell, which is exclusive to Premera members. Next slide. Members will also be assigned a primary care provider. So these PCPs or primary care providers will be responsible for coordinating and providing referrals for all specialty care. There's no pharmacy deductible under the Premera HMO plan, whereas right now under the Peak Care EPO plan, there is. And as you saw in the slides above, there are lower cost shares as well. Next slide. So some of you may be familiar with this slide. This is kind of the template that we used when we were originally setting up the SEB program, just to kind of show a high-level overview of what the individual plans look like in regards to some cost shares. So as you can see, the deductible there is $750 just for an employee only, just like it was under Peak Care. But the deductible for all other tiers is lower under this plan than under the Peak Care. There is still a 20% coinsurance. And then the maximum out of pocket, I'm 99% sure is the same. I'm pretty sure that one's the same. But there's no pharmacy deductible, so that is a change. And I just want to make one or two edits on this change. So urgent care, so the edit is that under urgent care subject to deductible, that yes should be a no because it's a copay, so it's not subject to deductible. And then I noticed at the bottom there, OOO instead of OOP for out of pocket. So that's just two callouts I wanted to make on this slide. And before we move on to some of the other plan cost shares, just wanted to mention, keep in mind that there could be other potential service area changes presented at the next meeting. So now we're going to get into some plan cost share overviews just to kind of show side by side what all of the changes are that we just went through. So next slide, please. First up, we've got the managed care and health maintenance organizations. And as you can see there on the far right, Premera Blue Cross's HMO plan is now in the place where Peak Care EPO used to be. All of the changes are in italics and underlined. So you can see the changes there for the medical out-of-pocket limit for KP Northwest, and then the new addition of the Premera HMO plan. Next slide. And same thing for the preferred provider organizations. The only change on this slide is that the UMP high deductible plan, their medical deductible is going up. So it's going from to $1,500 for a single subscriber and $3,000 for a family, for all the other tiers.
This is Dave for the record. Somebody had to go first, and there'll be more information about that specific change in the next presentation by Christine. It's essentially a federal requirement to maintain the qualified tax status of that plan, but didn't want to skip over the overall portfolio comparison. But if you have questions about that particular box and that change, I'd ask board members to just hold on to that until we get to the next presentation.
Next slide, please. So CAM is a big deal when it comes to our members and oftentimes the board. So we just kind of wanted to show a side-by-side comparison of what that looks like, especially because Premera is proposing the changes that they are. So as you can see, again, changes are in italics and underlined. And the Premera Blue Cross HMO plan is there in the far right. And kind of going back to what Dave was saying, which we'll get to on the next slide. Go ahead and change to the next slide, please. So for the uniform medical plan, CAM services have that $15 copay for all of their plans. And then you can see the Premera high PPO and standard PPO change there to the $25 copay for CAM services. You can also see how they align or line up against the access PPO plans for Kaiser Washington as well. Are there any questions before we move on to dental? All right, let's go ahead and move on. So next up, we're going to go through the dental and vision benefit offerings. Next slide, please. All right, so there's some changes to the the Delta Care plan for 2023. So pediatric care for children through age 19 will now be covered at 100%, less applicable copays. There is going to be coverage for composite fillings for posterior rear teeth, and providers will be paid a $25 preventive care incentive. So just wanted to make a note that in 2021, for example, only 22.5% of members, 22.5% of members had no preventive visit. And so in order to avoid higher costs of major dental work and for the health of the member, providers will be paid a $25 incentive to try and get more members to come in for those preventive visits. Pam
we're
has.
going to go to you next. Lauren, can you do the next slide, and then we'll go to Pam's question, because I want to make sure that we get the context of the entire portfolio first.
Yeah. All right, next slide. All right, so the following have no proposed benefit changes. So Uniform Dental Plan and Willamette Dental, Washington. And then none of the vision plans have any proposed benefit changes for 2023 either.
Okay, let's go back to slide 25. And Pam, I just want to add one more piece of context, and it might even anticipate your question. A couple of different things. We know these were proposals that Delta brought to the Healthcare Authority. These were not specifically requested by HCA. I wanted people to be aware of that piece of it. But we asked all of our contracted vendors and carriers and partners to attend all board meetings, and they have been attending virtually in the background. And I'm positive that Delta and Willamette have been listening to the proposals, because some of this language is very similar to some of the proposals that were described as part of a potential uniform dental plan benefit change in the future. And I do believe that Willamette has told us they want that they'll be observing how the uniform dental plan might change in the future, and we would anticipate that they might put forward some proposals as that decision package plays out. And I also anticipate that Delta may also have additional proposals in the future, depending on what happens with the uniform dental plan. But Delta did bring these as part of their bids to advance some changes within the Delta Care product line that's in SEB. And now, Pam, let's turn to you.
Dave, I think you anticipate every question I have. I appreciate the context and hearing it came from Delta, because it kind of felt a little weird, because it should be us proposing versus the provider proposing. But anyway, I was hoping, Lauren, you could explain one more time, because I was trying to text people, say, are we reading this correctly? Explain the $25 preventative care incentive. How does that work? I go get my preventative care. What happens?
So I'm full disclosure, I am not the dental plan account manager. I'm Kaiser, Wa, and Primera. So I don't know that much about this benefit. Dave actually might know more. But my understanding.
I can take the microphone, Lauren.
Okay, go ahead.
Yep, I'm definitely aware of this. So this is incentives to the providers to get members to utilize their preventive services. So, we have a significant proportion of the population that is not actually accessing their Class 1 benefits. And Delta is setting up a provider incentive to encourage that outreach to members who traditionally have not accessed preventive care. And if they actually get movement of people to use their preventive care benefit, then the provider will receive a one-time incentive related to moving the needle on getting actual utilization of the preventive benefit. So it's not an incentive to the employee or the member, it's an incentive to the provider for getting members who traditionally do not access preventive services to actually have those preventive services.
Appreciate that. That makes more sense. One other question, and I know we have talked about crowns a lot. And I'm wondering if at least is there any interest from Delta, including an incentive, or not an incentive, but covering more coverage for Crowns? Or is there any way we can encourage them to do so? Because I know we talked a lot about it at our last meeting.
I think that's absolutely my suggestion, Pam, would be that I was very pleased that Delta came forward with a couple of proactive proposals, watching again the board meetings and board discussions, and I anticipate that as we see what happens with the uniform dental plan proposal, that we would similarly, what often happens, it's not a guarantee, but what often happens in the portfolio is that when the self-insured medical or dental plan does something that is creates strong motivation for the rest of the portfolio to align with it, to avoid, everyone wants to avoid adverse selection, and so a lot of adverse selection is minimized by having more alignment of the benefits. So it's one of those things where I anticipate that that could certainly be on the table. Again, a lot more on our radar was changes for 2024 and beyond. Very happy that Delta brought a proposal that has a few components in it that they want to encourage within this particular product line. I do think we're going to see more proposals around dental from all three plans, essentially, as that decision package works its way through the process.
All right, thank you.
So I think that's squarely part of the 2024 conversation. And then Pete, you have a question.
Pete, you're on mute.
Oops,
Oh, there you go.
okay, one more time. About providers being paid a 25% preventative care incentive. Do you know, is that going to be in the form of a separate reimbursement unconnected to the specific claim for an individual, or is it in effect a higher reimbursement rate for the preventative service for that group of SEB members who, you know, have not been accessing the preventive care, but would show as a claims cost as opposed to some other type of accounting label?
I'm only 80% sure of the answer, Pete, so I'm going to ask to be able to follow up with that one at the next board meeting unless I get information before the end of the public meeting on it. But I'm not confident enough to answer that one off the cuff.
Okay, that's fine. Thanks.
Well, that's it for my slides. Are there any other questions before we wrap up? All right, back to you, Lou.
Thank you, Lauren. Appreciate it.
Yep.
The next agenda item, 2023 UMP benefit resolutions. Christine Davis, UMP account manager, IRB division, is going to introduce two UMP benefit resolutions proposed for 2023. Her materials are behind tab number 5. Christine, welcome.
Thank you, Chair McDermott. Hello, everyone. Like was just mentioned, my name is Christine Davis. I'm UMP account manager. And yes, today my presentation is about the Uniform Medical Plan, RFR 2022, aligned for benefit year 2023. Next slide, please. First topic today is an app-based behavioral health program. HCA requested information on available app-based behavioral health program options for SEB and PEB program members. Regions providing details on offerings for app-based behavioral health programs that could be offered to PEB and SEB program UMP members for a January 1st, 2023 implementation. HCA received authority in the 2022 supplemental budget to offer this program. HCA's intent is to increase access to behavioral health resources through an app-based solution. Next slide, please. Costco mail order pharmacy. Adding Costco as an additional mail order pharmacy beginning in 2023. Member experience will be similar to current offerings. Next slide, please. The HSA qualified high deductible plan, as derived from IRS Revenue Procedure 2022-24, for 2023, HCA plans to increase the minimum deductible for single subscribers from $1,400 to $1,500, and all other tiers from $2,800 to $3,000. For additional context, 2020 year, the plan was introduced for SEB fully leveraged from the PEB portfolio launched in 2012. No increase since its inception. After a decade, it is necessary to increase the minimum in order to maintain an IRS qualifiable high deductible plan. Next slide, please. Here on screen is the proposed resolution, SEB 2022-02, IRS minimum deductible for high deductible health plan. Beginning January 1st, 2023, the deductible in the UMP high deductible plan will be increased to $1,500 for single subscribers and $3,000 for all other tiers. And just to, for a reminder, these are the lowest deductibles authorized by the IRS to maintain HSA qualified plan status. Next slide, please. Shifting to the next topic, IRS Notice 2019-45. Please note this slide was presented before. It helps to give context to the notice. The board voted on the medical components last year, SEB Resolution 2021-15, included in the appendix for reference. For this presentation, we will focus on the pharmacy component. Next slide, please. On screen is the appendix from IRS Notice 2019-45. And as I just mentioned, we are going to focus on the pharmacy component this year. Next slide, please. IRS Notice 2019-45, HC recommends the UMP high deductible plan provide pre-deductible coverage at 15% cost share for certain high-value drugs within each drug class specified in IRS Notice 2019-45. Next slide, please. On screen is a table. This table shows specifics of what is allowed under the notice in terms of preventive care for specific conditions as shown in column 1 of the first column. The second column shows the diagnosis. And the third column shows certain value drugs HCA is recommending as allowed under the notice. This is an iterative process. Some of the differences, for example, are blood pressure medications. HCA will continue to evaluate if other drugs can be added in the future. Next slide, please.
Christine, just to the board's awareness, the notice from the IRS is very specific. It gets down to the exact mechanism of action of a drug. So it's very, very technical. So Christine's trying to just kind of have an overview of it, but that point that she just drew about blood pressure medicines, it's something that I anticipate many people would have questions on. Like the upper right-hand box has the word lisinopril or lisinopril hydrochlorothiazide. And many people who are on a high blood pressure med have either heard about lisinopril and they may be on something else. And the reality is many of the other blood pressure drugs have a different mechanism of action than being an ACE inhibitor. And so quickly going to get out of my swim lane. I can say the words, but I'm not going to be able to answer the technical side, nor do I expect Christine. But that's how technical the IRS notices get. And so when you know, we're bringing you this, we brought you medical last year. We said we needed some more time with pharmacy. This is why we needed more time with pharmacy, because it gets technical fast. And we're still anticipating or hopeful that we'll be able to bring you even more, but we don't want to hold up parts of the proposal that can make a real impact for people with things that are squarely under the IRS notice. And my favorite word with this board is iterative process. It takes years and you just keep moving the needle. So this is just that next step, but the IRS notice is very technical on this type of point. So just wanted to drive that home.
Thank you, Dave. Next slide, please. So this is a continuation of the table. And for additional context, insulin is already covered before deductible. Effective January 1st, 2023 through legislative mandate, Second and Gross Bill 5546, insulin will be covered with a cost cap of $35 for a 30-day supply. Next slide, please. And just to further show the table, and then also to reiterate that this captures certain high value drugs, and Dave described well as to why it's certain drugs. Next slide, please. The proposed resolution SEB 2022-03 UMP High Deductible Plan Preventive Care. Beginning January 1st, 2023, the UMP High Deductible Plan will cover the drug list presented to the board on June 2nd, 2023, prior to meeting the plan's deductible. Thereafter, HCA may alter this drug list to allow for pre-deductible coverage based on clinical evaluation and in accordance with IRS guidance.
Christine, just going to jump in again. You accidentally said June 2nd of 2023. You meant
Oh.
today's meeting. Yep, no, we're time traveling. But that last sentence, I just want to describe the words. That's why I was describing the agency wants to look even closer at things like blood pressure medicine. And if there is something that can be literally added, have been able to have literally been added to the page or the tables that Christine just presented, and we're able to do it, we might be able to implement even faster on some of those technical type of additions. And when it would all be about movement towards pre-deductible coverage on these types of ideas that are considered preventive. That second sentence is about asking the board to give the agency authority to implement, even in real time, first of the next month, even in some instances, if we can find a way for it to meet IRS guidance, rather than having to wait till the first of the next plan year. So we are asking the board to give the agency the discretion to expand this concept because it is much easier, and members also appreciate it when there's something that is to their advantage from a benefit design. It is a very rare circumstance that there is something that is a reduction in benefits ever that would happen mid-year. We would talk with the board about those instances. There'd be lots of those, but in this instance, we're talking about having some extra authority to be able to expand this concept as we learn more about the technical nature of it. So just wanted to highlight what that second sentence is really all about. And Lou, I see you have a question.
Yeah, Dave, if given this authority, will the board be notified of when these changes take place during the year?
Yes, we will bring information to the board about if there are types like over the next 6 months, if we discover things that could be added January 1, 2023, we'd let the board know at the board retreat. You gave us this discretion to expand that piece. Here's what was added to the list based on our additional understanding of the technical nature of that notice. So we would bring things to the board as an informational, but we would already be on the implementation path, and that can expedite the process. The members' advantage quite beneficial.
Understood.
Okay, next slide. And once again, I'm Christine Davis. I do welcome any questions, and connected to this presentation is the appendix with the references I shared in the presentation.
Any questions for Christine? Christine, thank you so much. Appreciate your time.
Thank you.
All right, next up is public comment. If there's anyone on Zoom that would like to provide comment. First, we're going to gather a list of speakers so we can manage it, and we're going to manage it out of the room there, Dave. Please click on your virtual hand if you would like to make a comment.
With Jessica.
Going once.
I'm just, going once. While Jessica just double checks, I'll answer Pete's prior question. I'll take a moment to answer that prior question because I do have the answer, and I'll give people more time, especially because we're a little bit ahead of the agenda, so I'll just fill for a moment. Pete, your question about how that $25 preventive preventive incentive would work, it is not included as part of the claims process. So it's not altering the allowed amount. It's not going to show up on an EOB. It's not going to count against the annual plan maximum. It's something that happens entirely in the background. It is, there's obviously a little bit of a cost associated with that's with the premium, but in the SEB context, it's a
Thanks, David. And that is interesting. So it will not come from the same, I don't know how to say this exactly, but stream of income that funds the PEB benefits generally, in which case it would, in theory, I guess if it was included as, I'm trying to wrap my head around how you can provide the funding, that revenue stream without doing.
Part of
Anyway.
admin instead of claims.
Okay,
Part
right,
of
it'll be an admin cost. Okay, great. Thank you.
Jessica, anyone from the public wanting to comment?
No one's come forward.
Okay. Next meeting is going to be June 23rd, 2022, 9 to 2. Dave, any final comments before we go to exec session?
Just a preview of the next meeting. For sure, we know that we'll take out the 2 resolutions that Christine presented for stakeholder review, and then bring them back, hoping the board will take action on them. We'd like to have the board take action on UMP benefit design resolutions in June whenever possible, just because it helps all of our finance folks feel a little bit more secure in the final rate process, that there's not any potential moving part on any benefit design. So we'll ask you to take action on those after stakeholder review. If there are, and there likely will be a follow-up presentation from Lauren on any other aspects of the fully insured procurement insights as we march forward into July on presenting rates and things that are embodied within those rates. So Lauren will have a second presentation with some additional pieces that just couldn't be brought today. And then we know for sure we'll have another executive session. There may be something else, but those are the things I feel confident will be happening at the next board meeting.
All right, board members, any questions or comments before we go to exec session?
Lou,
Yep.
sorry.
Yep.
I'm not a board member, but Dave, did you want to talk a little bit about having the next meeting be a virtual meeting?
Yes, thank you, Katie. Thank you. I completely forgot about that part. Yes, no, thank you so much for that reminder. Members of the board and the public will, if we rewind in time to the last May meeting, I brought forward that we anticipated that this meeting would be a hybrid meeting that would have physical space that members of the board or the public could come in person to the healthcare authority or continue to provide access remotely. There was a lot of kind of information that was just coming out right at we were having the last board meeting about who could do what, where, when, and how decisions can be made and what are the requirements. And we got to a place, especially where our agency recommendation for the board meeting, including today's, was to continue to have it virtually. So we began providing notices out that despite the initial words that I anticipated and said at the May SEB meeting, that we were going to encourage having a virtual meeting here. And just for awareness, I did enough change between the SEB and PEB meeting. The PEB meeting was 1 week later, where a lot of the stakeholders are same, and not that I'm saying that this provides adequate notice, but it actually could help with actual understanding of notice. A similar recommendation was made to the PEB board, and the PEB board agreed with it during the board meeting to continue to have virtual meetings for the time being. So I did want to make that recommendation formally to this board, especially for the next meeting. But at this point, since we're so close to the end of the board season, the recommendation actually would be to, unless circumstances change and we want to have a hybrid meeting, is to say for the rest of this board season, the meeting at the end of June and the meetings that are anticipated in July, to just plan to end this board season in an all virtual setting. And we would continue to support the board this way. And I'd be curious if there's any comments, concerns with that recommendation, because we'd like to implement that and make sure everyone's clear that that is how we proceed. But of course, your thoughts on that is important, but that is our recommendation. And it's a recommendation that the agency is making to roughly the dozen boards that it supports. We talk a lot about PEB and SEB here, but there are about a dozen total boards that the agency supports, and the agency is making the recommendation across the board to all of those entities. The other boards have some more year-round meetings, so they don't have a nice bookend of a cycle to talk about. But the recommendation here is to stay through the rest of the board meeting. Carrie, you have a question or a comment?
Yeah, actually, I'd like to make a motion that we continue to meet remotely through the 2022 board meeting season.
Is there a second?
Pam Cruz, I second the motion.
All in favor or any discussion? Does anyone have anything else they'd like to say about that? All in favor, say aye.
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 Any opposed? Motion carried. The remainder of the 2022 board season will be done remotely. Katie, did we handle that appropriately? Did we do that right?
Looks good to me.
All right.
I just want to thank the board for that. You know, we went back and forth on whether a formal vote was necessary, but it certainly is helpful and appreciate the unanimous support of that, and that makes it crystal clear. So thank you.
All right.
Thank you, Katie, for reminding me about that.
Any other questions or comments before exec session? All right. Pursuant to RCW 42.30.110 subsection 1L, the board will now meet in executive session to consider proprietary or confidential non-published information related to the development, acquisition, or implementation of state purchased health care services as provided in RCW 41.05.026. The exec session will conclude no later than 11:35 a.m. Board members, let's go ahead and take 5 minutes. We'll meet back here at 10:10. And we'll return to the public meeting after exec session to adjourn the meeting. And there's no further presentations for today. All right, we'll see you at 10:10.